So today we are going to learn about acoustic neuroma. This is a very important topic that has been repeated multiple times in various exams. So if you are getting this question for your exam, you have to write like this to score the perfect marks. Start from the definition. Say that it is a benign, encapsulated, slow-growing schwannoma arising from the vestibulocochlear nerve. Coming to the pathology, say that it originates from the Schwann cells of vestibular division of the vestibulocochlear nerve. So this is the internal auditory canal, and superiorly we can see superior vestibular nerve and the facial nerve, which are divided by the Bill's bar. Then inferiorly we can see cochlear nucleus and inferior vestibular nerve. So most commonly this tumor arises from the inferior vestibular nerve. Now it grows and appears on the CP ankle. What is CP ankle? Cerebellopontine ankle. Then it will go anterior posteriorly, then involve the trigeminal cranial nerve. Then it will grow inferiorly to involve the 9, 10, 11 cranial nerve. So it has grown anterior posteriorly to involve the 5th nerve and inferiorly to involve 9, 10 and 11 cranial nerve. Then it will cause the displacement of the brain stem, and at last it will give pressure on the cerebellum. Now on giving pressure to the cerebellum, it is increasing the intracranial pressure. Now coming to the histology, here we can see elongated spindle cells with rod-shaped nuclei arranged in palisades. So this nuclear palisading is known as verrucate body. You can also see loose reticular tissue, that is the Antony B cluster, and the palisade, that is the Antony A cluster. Now coming to the classification, it is depending on the size. First is intracanalicular, that is it is confined to the internal auditory canal. Then it's small size tumor, that is up to 1.5 centimeter. Medium sized tumor, that is up to 1.5 to 4 centimeter, and large sized tumor which are more than 4 centimeter. Now the most important clinical features, it usually affects 40 to 60 years age group. The males and females are both equally affected. And now if it is intracanalicular, that is within the internal auditory canal, we can see cochleovestibular symptoms because they are giving pressure on the cochlear and vestibular nerve. So cochlear nerve pressure will give rise to progressive unilateral sensorineural hearing loss and tinnitus. Also, there will be difficulty in understanding the speech. The speech discrimination score will be poor, and that will be out of proportion to the hearing loss. Then what are the vestibular symptoms? Imbalance and vertigo. Now coming to the cranial nerve involvement, the 5th cranial nerve is first to involve, and it will cause decreased corneal sensitivity and numbness in the face. So this is when the tumor is 2.5 centimeter and occupies the CP ankle. Now what are the 7th nerve symptoms? The very important thing to remember that the 7th nerve sensory fibers are affected first. The motor fibers are resistant because they are very thick and they are affected very late. So what are the sensory symptoms? First symptom is the hypoesthesia of the posterior meatal wall, and that is known as Hitzelberger sign. Then there can be loss of taste and decreased lacrimation. Coming to 9th and 10th cranial nerve, there can be dysphagia and hoarseness. Now, if the brainstem is involved, there can be ataxia, weakness, numbness, and exaggerated reflexes. On cerebellar involvement also, we can see ataxia, dysdiadochokinesia, and other cerebellar symptoms. And increased intracranial pressure give rise to headache, nausea, vomiting, and papilledema. Coming to the investigation, the most important investigation is audiology, where we are doing pure tone audiometry. We will get sensorineural hearing loss in high frequency. And speech audiometry will give poor speech discrimination. There is rollover phenomenon present. Recruitment phenomenon is absent. Recruitment is usually seen in cochlear lesion. This is a retrocochlear lesion where the nerve is involved, not the cochlea. And then there is a SISI test, short increment sensitivity test. The score will be 0 to 20%, and tone decay test will be faster. The tone will decay fast. Now coming to the stapedial reflex, it will be absent. Vestibular test like caloric test will be absent. Neurological test has to be done to look for cranial nerve, cerebellum, brainstem, and fundus involvement. Radiological test, the MRI with gadolinium contrast is the gold standard to look for the tumor. You can also perform CT or vertebral angiography. Then you have to do BERA, where you can see delayed wave 5. The intraoral latency difference of the 5 will be more than 0.2 milliseconds. Then do the CSF examination. Now what are the DDs? It can be Meniere's disease, meningioma, which is another tumor and then it can another CP ankle tumor, and then it can be arachnoid cyst or primary cholesteatoma. Coming to the only treatment that we can do is surgery, and then we can also do radiotherapy. So the surgery can be a neurosurgery approach or an ENT approach. So neurosurgery approach means middle cranial fossa approach. ENT approach means translabyrinthine approach or suboccipital approach, or the combined translabyrinthine and suboccipital approach. So these approaches are based on the size of the tumor. Now coming to the radiotherapy, we can do gamma knife or X knife. So this gamma knife is a stereotactic radiotherapy which will shrink the tumor. Localized radiation is given. It is not like the external beam radiotherapy. Then we can also use cyber knife, which is a modification. So this was all about acoustic neuroma, and if you want this full notes, it is available in our Telegram channel and link is given in the comment section. Thank you.